আমি শুরু করতে পারি না?
ওকে স্যার।
ওকে, তোমাদের সবাইকে আমার ক্লাসে শুভেচ্ছা জানাচ্ছি। নিশ্চয়ই তোমরা সবাই ভালো আছো। আজকে আমি যে বিষয়টা নিয়ে তোমাদের সঙ্গে কথা বলবো সেটি হলো CKD, that is chronic kidney disease. You know, the prevalence of non-communicable disease, especially hypertension, diabetes mellitus, ischemic heart disease, then COPD, bronchial asthma, chronic kidney disease. এই ডিজিজগুলোর প্রিভ্যালেন্স ওয়ার্ল্ড ওয়াইড প্রতিনিয়ত বেড়ে যাচ্ছে। তো সিকেডি অর ক্রনিক কিডনি ডিজিজ এর যে প্রিভ্যালেন্স বলা হচ্ছে যে স্টেজ 3 to 5 স্টেজে যখন সিকেডি চলে যায় তখন এর প্রিভ্যালেন্স অ্যাবাভ 60 ইয়ার্স এজেড পিপলের 5 to 7%। তো ফর্চুনেটলি এটা দেখা যায় যে স্টেজ 1 to 3 তে সিকেডি যে পেশেন্ট গুলো থাকে, যে ফর্চুনেটলি দেখা যায় যে মেজরিটি পেশেন্ট এরা স্ট্যাটিক থাকে আর নন প্রোগ্রেসিভ হয় এবং মেজরিটি পেশেন্ট এন্ড স্টেজ রেনাল ডিজিজে যায় না। ক্রনিক কিডনি ডিজিজ আমরা আজকের যে আমাদের যে ডিসকাশন, এই ক্রনিক কিডনি ডিজিজের আমার লেকচারে আমি চেষ্টা করব যে ক্রনিক কিডনি ডিজিজের ডেফিনিশন, স্টেজিং, ইটিওলজি, প্যাথোফিজিওলজি, clinical manifestation, then complications due to CKD, investigation planning, management, এই বিষয়গুলো সংক্ষিপ্ত আকারে একটি ক্লাসে যতটুকু দেওয়া যায় আমি চেষ্টা করব বলার জন্য। সিকেডি ডেফিনেশনে আমরা জানি যে এটা ইটস ইরিভার্সিবল ডিটেরিয়েশন অফ রেনাল ফাংশন which develops over a period of years. একটা জিনিস শুরুতেই বলে নেই যে সিকেডি হতে হলে যে জিএফআর অ্যাবনর্মাল থাকতে হবে, এই জিনিসটি যেন আমাদের মাথায় না থাকে। কারণ সিকেডি ডেফিনেশনে বলা হয়েছে যে abnormalities of structure of kidney or function of kidney that persist more than 3 months. That is, the structural abnormality persisting more than 3 months or functional abnormality persisting more than 3 months should be considered as CKD. And to fulfill the criteria to define the CKD, the markers of renal damage and or eGFR, decline eGFR, that is less than 60 ml per minute per 1.73 square meter. So, if there are any markers of renal damage persisting more than 3 months or reduced GFR less than 60 ml per minute per 1.73 square persisting more than 3 months should be considered as CKD. So what are the markers of kidney damage that should be learned first? The markers of kidney damage: moderately increased or severely increased albuminuria. Moderately increased albuminuria means previously that was defined as microalbuminuria, you know, a spot urine collection, albumin creatinine ratio 30 to 300 milligram per gram, or 24 hours urine যদি albumin 30 to 300 milligram এই রেঞ্জে থাকে, এটাকে আমরা মাইক্রোঅ্যালবুমিনুরিয়া বলতেছি। ইট ইস মডারেটলি ইনক্রিজ অ্যালবুমিনুরিয়া। আর সিভিয়ারলি ইনক্রিজ অ্যালবুমিনুরিয়া আমরা ডিফাইন করতে পারি যদি ACR, albumin creatinine ratio, more than 300 milligram per gram, or 4 hours urinary collection albumin more than 300 milligram থাকে। So moderately increased or severely increased albuminuria, this is one of the important marker of kidney damage. Another markers of kidney damage is the abnormal urinary sediment. That is the presence of RBC, that is the hematuria. Then another electrolyte disturbance or any abnormalities due to tubular dysfunction. Then histological abnormalities of the kidneys, then structural abnormalities of the kidneys, and previous kidney transplantation. So these are the markers of kidney damage. I would like to say again that the moderately increased albuminuria or severely increased albuminuria, then abnormal urinary sediment, electrolyte disturbance or other abnormalities due to tubular dysfunction, histologic abnormalities of the kidneys, structural abnormalities of the kidneys, and previous kidney transplantation. So these are the markers of kidney damage and or reduced eGFR that I already told that less than 60 ml per minute per 1.73 square meter. So to define the CKD, the markers of kidney damage and or reduced eGFR. And you know the staging of CKD, depending staging of different has done on depending on the eGFR as well as urinary or other presence of other kidney markers of kidney damage. And that was done by US National Kidney Foundation, and that is the Kidney Disease Quality Outcome Initiatives 2002. You know the stage one when the GFR more than 90 or more than 90 and the evidence of kidney damage. And it is defined as mild CKD. You know, it's always asymptomatic and prevalence about 6.5%. And stage 2, kidney damage and GFR, that is a 60 to 89. Stage 3A, GFR, you know, eGFR 45 to 59. And this is the moderate CKD. It is prevalence about 4.5%. And still, stage 3A patient usually asymptomatic. This is the problem, that the patient developed CKD and already moderate CKD, but patient is still asymptomatic. And stage 3B, that is the eGFR 30 to 44. Some patient may develop anemia, and fortunately, most of the patient non-progressive or static up to this stage. And we considered the stage 3. This is the, I should say, this is the stage up to this, and the kidney function remains static or non-progressive. But whenever the CKD cross the stage 3B, there is a stage 4, this is usually then progressive and ultimately leads to end-stage renal disease. So whatever stage 4, in stage 4, the eGFR 15 to 29, you know, and it is considered as severe CKD. And it is seen that the first symptom usually appears when the eGFR less than 20. And when the GFR declines progressively, the electrolyte disturbance takes place. Stage 5, this is defined as end-stage renal disease, or it is the renal failure, kidney failure. The GFR 15 or patient is on dialysis. And mostly the symptoms becomes more significant and complication appears. And requirement of dialysis varies from individual to individual. Usually, whenever the GFR less than 10, usually the dialysis required. So these about staging, stage 1, 2, and 3, up to the stage 3, usually patient remains asymptomatic. And fortunately, most of the patient remains static or non-progressive up to the stage 3. And you see the anemia usually appears in the stage 3B in some patients. And mostly patient becomes symptomatic when the GFR less than 30. That is usually in the stage 4. And it is the stage 5 when the life becomes incompatible or death is likely without renal replacement therapy. That is the end-stage renal disease. The GFR is usually 15 or less than 15. আমি এফাকে একটু বলে নেই যে আমার লেকচারটা আমি চেষ্টা করেছি যে ডেভিশন বেজেই বলার জন্য আর কিছু এক্সপেরিয়েন্স কিছু নলেজ তোমাদের মাঝে শেয়ার করার জন্য। ডেভিডসনে আমি দেখেছি যে খুব সুন্দরভাবে আমাদের টপিকসটা বলা আছে। আমার মনে হয় যে আমার লেকচার শোনার পরে তোমরা ডেভিডসনটা একটু ভালো করে পড়লেই এই টপিকসটা তোমাদের সুন্দরভাবে বুঝতে পারবে এবং তোমাদের মনের মধ্যে গেঁথে যাবে। So, what's about epidemiology of the CKD? I have already told you in the stage 3 to 5, the CKD prevalence about 5 to 7% in the age of 65 or more than 65. And normally, in advancing age, our GFR progressively declined. And in presence of risk factor or the disease that associated with the development of CKD, the GFR become progressively decline along with the age-related changes. So, what's about pathophysiology? There are a lot of causes remains behind the development of CKD. The most culprit one is the diabetes mellitus. And it contributes about 20 to 40% cases of CKD. Another one is the hypertension, it's about 5 to 20%. And glomerular disease, 10 to 20%, interstitial disease, 20 to 30%. And systemic inflammatory disorder, congenital inherited disorder, renovascular disorder. All these disorder may lead to CKD. And the inappropriately or inadequately addressed or treated acute renal failure may lead to CKD. So how the hypertension or diabetes mellitus precipitate CKD? In hypertension, there is progressive thickening of the artery, renal vasculature, and narrowing of the lumen. That leads to reduced perfusion of the kidney, leads to reduced GFR, stimulation of secretion of renin, and that renin ultimately leads to stimulation of renin-angiotensin-aldosterone system, and that leads to increased heart rate, vasoconstriction, sympathetic activity. Ultimately, again, there is reduced renal perfusion, development of hypertension, and reduced renal perfusion. So there is development of vicious cycle, and ultimately that leads to renal ischemia, glomerular sclerosis, and irreversible loss of nephron. Another thing is the diabetes mellitus. The development of CKD and diabetes mellitus is a complex procedure, pathophysiology, I should say, because in diabetes mellitus, there is persistent hyperglycemia. The persistent hyperglycemia leads to free radical oxidative stress, oxidative stimulation, leads to synthesis of pro-inflammatory cytokines and inappropriate secretion of growth factor. And all of these ultimately leads to there is mesangial expansion, mesangial proliferation, podocyte distortion, podocyte atrophy, then glomerular sclerosis and glomerular basement membrane thickening. And all these things ultimately leads to irreversible loss of nephron. And whenever there is loss of one nephron, the blood supply divert from that nephron to another one, and there will be hyperfiltration or high GFR in another nephron. And ultimately, the load or increased pressure leads to glomerular sclerosis. And there is also the repetition of cycle, and that leads to reversal loss of nephron and development of CKD. So these two disorders are the most important causes of development of CKD. And you see the elderly patient who are presented usually in the later stage of CKD, usually is stage 3. And in that case, the biopsy is rarely done because by this time the kidney becomes smaller in size and the biopsy is skip procedure. And the structure is totally so distorted that the information is becomes difficult to draw, and histological information, and usually it does not alter the management plan. Now, what are the clinical manifestation of CKD? The most worst things of the CKD is that the patient remains asymptomatic despite the complete or irreversible deterioration of large number of nephrons. And initially, they may be diagnosed incidentally by the raised urea or creatinine in presence of hypertension or albuminuria or without anemia. And for this reason, if a patient or an individual have diabetes or hypertension or other disease that have potentiality for development of CKD, should be screened routinely or regularly for development of CKD. Because the clinical sign symptom develop in the later stage, and initially it is diagnosed by lab investigations. So if a patient of hypertension presented with albuminuria or proteinuria, with anemia or without anemia, so there is a strong suspicion the patient might have CKD. So raised urea or raised creatinine level is the incidentally diagnosed case of CKD. Patient, I have already told you, the patient usually remains asymptomatic unless the GFR less than 30 ml per minute per 1.73 square meter. And that is the stage usually 4 or 5, already 4 stage. And initial complaints by the patient usually noxurias, though it is a non-specific symptoms, and that noxuria usually occurs due to lack of concentrating ability of the tubules and increased osmotic load. And subsequently, whenever the GFR around 15 to 20, the patient develops symptoms like tiredness or breathlessness, which is maybe due to anemia. There might be pruritus, anorexia, nausea, vomiting. There might be hiccup. There might be muscle twitching, drowsiness, fits, and then might be coma also. You know, the kidney has excretory, metabolic, and endocrine function. So when there is food or beyond that, all the excreted, and the patient presented the symptoms or signs relevant to that excretory, metabolic, or endocrine dysfunction. So these are the general symptoms whenever we should assume that the patient might have CKD and advancing stage already. Then the other features that to immunodeficiency, CKD is saying that there is both cellular and humoral immunity depression. So the patient are susceptible to develop infection. And it is said that the infection is the second most cause of mortality of patient of CKD, second in position. Other one is the first important one is the cardiovascular catastrophe. And most of the infection is saying that the access excess device related, and other infection like pneumonia. So in CKD management patient, the other chronic illness patient like other patients should receive a vaccination against like pneumonia. Certain manifestations due to hematological abnormalities. In CKD, there is platelet dysfunction or thrombocythemia. There is increased bleeding tendency. There is increased bleeding time. And the problem in whenever we use anticoagulant on dialysis, there is chance of bleeding is more. The important thing is that anemia. The anemia, the most important thing, the hematological problem that arises in patient is CKD. And in the stage, advancing stage, usually it's seen that in the stage 5, some of the patient may develop hemoglobin level 5 to 7 grams per deciliter. So anemia is common problem, but CKD caused by polycystic kidney disease, in that case, you may not found anemia, whether anemia is less or even absent. Another presenting problem that might be electrolyte abnormalities. The electrolyte abnormality is very important. The patient might have hyperkalemia, sodium retention, patient might have metabolic acidosis, there might be fluid retention, and especially in advanced CKD, sometimes there is disproportionate fluid retention in mild cases. Especially in renal artery stenosis, there might be episodic pulmonary edema. Exceptional thing is that in patient with tubulointerstitial disease, there might be salt wasting disease, and that patient may require high intake of sodium and water to prevent the water salt depletion. So electrolyte abnormalities varies from individual to individual. Another important thing is the development of metabolic acidosis. The bicarbonate regeneration as well as hydrogen excretion is problematic in patient with CKD. So the patient might develop metabolic acidosis. And the metabolic acidosis is usually asymptomatic. But there is chance of increased tissue catabolism, decreased protein synthesis, there is increased chance of metabolic bone disease, and it increases the rate of decline of renal function. So we should not allow acidotic environment. Clinical manifestation related to endocrine dysfunction. In CKD patient, either male or female, there is chance of decreased libido. That is partly due to hypogonadism resulting from hyperprolactinemia. Another problem is regarding insulin metabolism. In CKD patient, we see that there is defective metabolism of insulin in the renal tubules, as well as some sort of insulin resistant and decreased appetite of the patient. So dosing of insulin in a patient of CKD is individualized. The presentation related to neurological and muscular function. CKD patient might develop generalized myopathy, and that myopathy is due to poor nutrition, vitamin D deficiency, hyperparathyroidism, and electrolyte disturbance. So you should remember 4 things behind the myopathy. One is the poor nutrition, hyperparathyroidism, decrease vitamin D as well as electrolyte disturbance. Some patients may develop muscle cramping, and some patients may claim of restless leg syndrome. It is seen that the patient develop both sensory and motor neuropathy in the form of reduced reflex or absent reflexes, paresthesia, and some patients rarely complain of food drop. So there might be neurological and muscle dysfunction of patient of CKD. Now, the most important thing is the cardiovascular disease. You know, the mortality of CKD patient primarily mostly due to cardiovascular catastrophe. And usually whenever the stress-free CKD or GFR is more worse, and or there is a proteinuria or albuminuria, these reduced GFR and or albuminuria or proteinuria all are individual risk factor for development of cardiovascular or coronary artery disease with patient of CKD. And there is most of the patient remains hypertensive, there is left ventricular hypertrophy, and that may develop to dysarrhythmia and even sudden death of the patient. In end-stage renal disease, inadequately treated patient may develop pericarditis, uremic pericarditis. There might be pericardial tamponade, constrictive pericarditis. Another important thing is that in CKD, there is increased phosphate level due to reduced excretion of phosphate, and especially whenever the stage is 3B or more, there is hyperphosphatemia, and that phosphate may induce hissing, generalized hissing, and induce secretion of prostaglandin, induce secretion of fibroblast growth factor 23, one of the important indicator of mortality of the CKD patient. Independent predictor of mortality of CKD patient is the fibroblast growth factor 23 that is synthesized in response to increased phosphate level. And these increased phosphate may bind with calcium, causing deposition of calcium in the vessel, and there will be less compliance of the vasculature, hardening of the vessel, etc. One of the important consequences is the metabolic bone disease, in patient with CKD. And considering this metabolic bone disease, vitamin D, calcium, phosphate, and fibroblast growth factor, parathyroid gland, and parathyroid hormone. These are the relevant things. And in a CKD patient, there is reduced production of active vitamin D level, there is 125 dihydroxycholecalciferol, and that leads to decreased active vitamin D, leads to decreased absorption of calcium from the intestine, that leads to hypocalcemia, and along with reduced excretion of phosphate via the kidney, that hyperphosphatemia, hypocalcemia, all stimulate the secretion of parathyroid hormone from the parathyroid gland, and ultimately there will be secondary hyperparathyroidism. And these increased parathyroid hormone stimulate the bones, osteocyte, osteoclast, and increase osteoclastic activity. There will be bone resorption. That is the increased bone turnover. This is known as osteitis fibrosa cystica. And the patient may claims of bone pain. There will be fracture in exposure to minimal trauma. And on imaging, there will be cystic bone resorption, cystic in the phalanges, especially in the phalanges. So this is the osteitis fibrosa cystica. Another thing is the osteomalacia and osteoporosis, and other thing is the the low bone turnover disease, that is the adynamic bone disease, that might occur due to over-treated vitamin D metabolites. That should also be remembered. So, osteomalacia, osteoporosis, osteitis fibrosa, cystica, and adynamic bone disease, these are the metabolic bone disease. And initially, when in the advancing stage of CKD, there is hyperphosphatemia, and this hyperphosphatemia causes increased secretion of fibroblast growth factor 23 from the osteocyte. And the initial stage that fibroblast growth factor 23 try to excrete the phosphate via the kidneys, and ultimately that compensatory mechanism fails and the hyperphosphatemia persists. So metabolic bone disease is an important presenting problem of patient of CKD. And over-treated hyperphosphatemia may precipitate osteomalacia. Now, what's about investigations of CKD? How will you plan investigation for a patient with CKD? We have 4 aims whenever we consider the investigations of patient of CKD. Number 1, to detect any possible cause, so that if we treat the cause, we can correct the condition. If there is any possible cause, some investigation may be planned. Number 2, is there any reversible factors or not, like hypertension, like sodium fluid depletion, or any nephrotoxic drugs, etc., or any obstruction, urinary tract obstruction. So certain investigation are planned to detect any reversible factors. Another investigations or some investigation are planned to see the complications of CKD. And certain investigations are to be planned to see the CVD or cardiovascular risk factors. So 4 aim: identification of cause, identification of reversible factors, to see the complications of CKD, and to assess any cardiovascular risk factors or not. So routinely we used to do that is the blood urea and serum creatinine to see the static or progressive stage of CKD, to compare the previous record. Then urinalysis, and to see the to quantify the protein in urine or any abnormalities in the urine, that is the presence of RBC or cast. Then electrolyte, especially potassium, there might have hyperkalemia. Then calcium, phosphate, parathyroid hormone, and 25-hydroxy vitamin D. Serum albumin may be asked to do, because hypoalbuminemia indicates active inflammation or malnutrition. We should do full blood count, especially hemoglobins, iron, ferritin, folic acid, folate, and vitamin B12, so that to see the non-renal anemia or presence of non-renal anemia or not. Is there any iron deficiency or vitamin B12 deficiency or folic acid deficiency? And we should do assess the cardiovascular risk factor, lipid profile, blood sugar, hemoglobin A1C. We should do the hepatitis B screening or HIV screening if there is plan of dialysis or transplantation. We should do ECG if the patient age is more than 40 years, or is there any evidence of hyperkalemia or other cardiac disease. And other investigation should be planned depending upon clinical clue, especially if you assume that the patient might have disease that develops CKD, like certain systemic inflammatory disease like systemic lupus erythematosa. So in other investigation will depend upon the presence of clinical clues. Now, what's about management plan of a patient of CKD? There are some aims. We should have some aims in managing of the patient of CKD. Number one, we know that it's irreversible condition, so we cannot feedback the patient to normal one, but we can prevent or slow the speed of progression of renal damage. So number one is to prevent or slow the progression of CKD. Number one aim. Number two, we can limit the physiological adverse effects of CKD on skeletal and hematopoiesis. Number three, we can reduce the risk factors, and the management plan for preparation of patient for RRT, that is the renal replacement therapy infuser. So 4 aims we should keep in mind. One thing is the prevention or to slow the progression of CKD, to limit the adverse physiological effects on the skeleton or hematopoiesis by the CKD, reduce the risk factors, and to prepare the patient for RRT. And to fulfill all these aims, we treat the patient or manage the patient by giving certain drugs, by counseling the patient, and by taking certain general measures, including dietary and lifestyle modification. So what's about pharmacological measures? One thing is important is that treatment with antihypertensive, and it is seen that reduction of blood pressure, that is treatment of hypertension, definitely slow the progression of CKD. Not only that, the other comorbidities of CKD or hypertensive patient or complication of hypertensive patient definitely reduce, like heart failure, stroke, peripheral vascular disease. And it is seen that use of any agent that slow the decline of CKD. So what is the goal of blood pressure in a patient with CKD? Usually we said that it is less than 130 by over 80 millimeter of mercury. But when there is advancing CKD, that is the proteinuria more than 1 gram per 24 hours, or that is the PCR more than protein creatinine ratio more than 100 milligram per millimole, or ACR more than 70, in that case, the goal is the 125 by 75 millimeter of mercury. So use of antihypertensive is very much important, and the maintenance of blood pressure within our goal is very important. Number two, to address the proteinuria. It is seen that if you hold the proteinuria or we reduce the proteinuria, it will slow down the progression of CKD. And in this context, ACE inhibitor and ARB is very important. They reduce the proteinuria, they reduce the mortality and morbidity of cardiovascular disease, risk factor, and reduce hypertension. So use of ACE inhibitor ARB is very important. Then the dietary advice and lifestyle modification. Protein restriction in in observation in animal models, it is seen that it is beneficial to reduce the progression of CKD. But the study in human being is not so established, but it is said that in advancing CKD, especially stage 4 or 5, the limitation of protein intake and calorie maintenance by appropriate calorie maintenance by carbohydrate, fat, as well as restriction of potassium, restriction of phosphate containing diet, and quitting of smoking, and exercise and maintenance of body weight in optimum body weight maintenance slow the progression of CKD. So this is about dietary and lifestyle modification. What's about lipid lowering therapy? You know that in CKD there is hypercholesterolemia, especially hypertriglyceridemia, and there is reduction of HDL. So it is seen that use of lipid lowering agent reduce the vascular event in non-dialysis patient, and some evidence suggests that control of dyslipidemia slow the progression of renal disease. Now the important thing is the management of anemia. You know the anemia, it is normocytic normochromic anemia, and it occurs due to different causes, especially lack of erythropoietin, and also there is resistance of erythropoietin, there is reduced lifespan of RBC, there is platelet dysfunction and capillary fragility leads to increased tendency to bleed, and there is suppression of bone marrow by uremic substance, also reduced intake, absorption, and utilization of iron. So a lot of things may remain behind the development of anemia in CKD patient. And due to this anemia, CKD patient may be presented with lot of symptoms or non-specific symptoms. So the assessment of iron deficiency is important in patient with anemia or with CKD. Not always it is due to erythropoietin, only the erythropoietin deficiency. And erythropoietin administration may be ineffective in presence of iron deficiency or in presence of active inflammation, active infection, malignancy, or aluminum overdose. So if during giving of erythropoietin, we should address the other things like iron deficiency or active infection, inflammation, or anything else. The problem is that erythropoietin administration may increase the blood pressure level. That is, it may predispose to hypertension, it may predispose thrombosis, it may reduce, it may invite other complications. So our target is that to maintain the hemoglobin level is the 11 to 12 gram per deciliter. The management regarding the fluid and electrolyte balance. In advancing CKD, there might be evidence of fluid retention. In that case, sodium intake should be restricted, usually within 100 millimole per day. And sometimes loop diuretic may be necessary for fluid overload. And for treatment of hyperkalemia, we should advocate our patient to stop or to reduce the dose of potassium sparing diuretic or ACE inhibitor or ARB. What's about acidosis? Acidosis should be corrected, I have already told you. And we have to maintain bicarbonate level more than 22 millimole per liter. For that, sodium bicarbonate we can prescribe. And if there is it may cause retention of fluid, hypertension, so substitute might be calcium carbonate. The advantage of calcium carbonate use, it is also binder of dietary phosphate. Regarding potassium level, we should restrict intake of potassium less than 70 millimole per day, especially in late CKD. And for treating hyperkalemia for a short term, we can prescribe calcium resonium, but for chronic use, it is not advocated. What's about renal bone disease? That is a metabolic bone disease. We should treat the patient with active vitamin D if there is hypocalcemia or parathyroid hormone level more than 2 times of normal. And we should maintain the parathyroid level within 2 to 4 times of normal range. For hyperphosphatemia, we should advocate our patient to avoid or restrict the phosphate-containing diet like milk, eggs, cheese, and protein-rich food. And we can prescribe phosphate-binding drug like calcium carbonate. A new agent like polymer-binding phosphate binder can be used. And another thing is the tertiary hyperparathyroidism. Constant stimulation of hypocalcemia to parathyroid gland make it autonomous. And the parathyroid gland continuously secrete parathyroid hormone irrespective of calcium or phosphate level. That is a tertiary hyperparathyroidism. In that case, parathyroidectomy may be necessary. And alternative to parathyroidectomy, a certain calcimimetic agent can be used that binds with calcium sensing receptor and decrease parathyroid hormone secretion. The cinacalcet, one of the agents. And parathyroidectomy, usually total 4 parathyroid gland is not operated or resected, usually 3 or 3.5. And some of the parathyroid gland is placed subcutaneously, especially usually in the arm, so that some amount of parathyroid hormone remains. Important another thing is that whenever we refer the CKD patient to our nephrologist, today's discussion usually regarding CKD from as an internist, we have discussed the general things of patient of CKD, but sometimes we need to refer the patient to our nephrologist colleague. So what are the indications of referral of CKD patient to nephrologist? If the age of the patient less than 40 years, that is the younger patient. If the patient has stage 4 CKD or worse condition is worse, that is GFR less than 30. If there is rapid deterioration of renal function. Another thing is that if there is significant proteinuria, that is the PCR more than 100 or ACR more than 70, and if there is significant hematuria. So in those conditions, that is the age less than 40 years, stage 4 or 4 CKD or more, rapid deterioration of renal function, and a significant proteinuria and significant hematuria. In those situations, we should refer our patient to the nephrologist for better management. So I think this is about CKD patient. And in case of end-stage renal disease, the life is not possible or death is likely without renal replacement therapy. And the renal replacement therapy like hemodialysis, hemofiltration, hemodiafiltration, peritoneal dialysis, and also renal transplantation. And usually in the stage 4, we should prepare our patient for renal replacement therapy. At least it is 1 year before we should plan for renal replacement therapy, including counseling and other measures. And this is about CKD. আমার মনে হয় তোমরা আজকে যদি তোমরা ডেভিডসন আজকালের মধ্যে একটু পড়ো, তাহলে জিনিসগুলো তোমাদের জন্য বেশি বোধগম্য হবে এবং খুব আমার মনে হয় খুব সহজেই বুঝতে পারবে। তোমরা টপিকসটা ভালো করে পড়বা, তোমাদের জন্য অনেক শুভকামনা। তোমরা সবাই ভালো থেকো, ধন্যবাদ।
ধন্যবাদ দিছে তো, শুভকামনা। শুভকামনা সব শেষ।